Welcome to the AMSSM Sports Economics Bite-Size Series. I'm Dr. Marcia Newby-Goodman, and in each episode, we'll tackle a practical sports medicine topic through an economic lens, providing quick, focused insights that help you deliver high-value care while navigating the realities of today's healthcare environment. Whether you're in the clinic, training room, or on the sidelines, these bite sized discussions are designed to be practical, relevant, and immediately applicable. Thanks for listening. Let's dive in.
Hi, this is Dr. Shane Hudnall. I'm the program director of the Cone Health Sports Medicine Fellowship, and today I'm going to give a presentation on sports medicine billing and compliance. Our objectives today are to identify the required elements for different E&M levels, to understand medical decision making and unpack that, and learn to link your documentation to your billing level. A couple key points I want to go over are, first of all, don't rely on how the visit felt as far as how you code. There'll be times where you'll say, well, this feels like it should be a level 4. Really rely on the medical decision making and the time spent in the visit, whichever you choose for how you code it. And just recall that if you didn't document it, it didn't happen. When an auditor is going through your charts and looking at your billing level, it needs to be in there. So the billing E&M levels, they rely on one of two things, either the MDM, which we'll go over here in a moment, or the total encounter time. So this is the time spent in the chart, and now it must be on the same date as the encounter. So if you did chart review the day before or wrote your note the day after, that does not count. But on the day of the encounter, it includes medical record review, writing the note, time spent that day on imaging and reviewing that imaging with the patient, coordinating care for the patient, and just counseling, answering questions. All of that is included if you're going to bill on time. Now, the history and examination portion has gotten a lot simpler since the beginning of the decade when they changed the rules on this. You just need to have a chief complaint and a medically appropriate history and physical. And no longer do we have to count elements. Now, often the most confusing part of billing is the medical decision making, and this is the most important part for this talk. It's divided into three parts. So your diagnoses, those are the problems and the complexity of those problems, data, which have different categories and points assigned to those, and risk, minimal, low, moderate, or high. And each of these three parts gets a level from 1 through 5, that we don't use 1 much anymore. So pick the level for those three parts, and at least 2 of those 3 have to meet a level to bill there. So if your diagnosis category gives you a level 4, data a level 2, and risk a level 3, at least 2 of those are a level 3, so you would bill a level 3. The way I like to teach it is you're billing the median of those 3. So in that same example of a diagnosis level 4, data level 2, risk level 3, 3 is your median. So that's the level that you would bill for on that visit. And there could be a lot of information here. So I'd like to give some examples to most of what we see in sports medicine for the diagnoses section is going to be a level 3 or level 4. But these are just the different things that go into each category. So moving on to the next slide where I can give you some examples. So a level 2 would be a self-limited or a minor problem. A level 3 would be 2 or more of those self-limited or minor problems that you don't have to do much for. Uh, it also includes a level 3, one stable chronic illness. Now, a chronic illness is defined as one that is expected to last at least a year or until the death of the patient. So someone that comes in with arthritis that is improved would be a good example of a stable chronic illness in sports medicine. Also in level 3 is an acute uncomplicated illness or injury that has low risk and expected full recovery, like a sprain or a strain. And then moving on to level 4, this is where you get into chronic illnesses that have an exacerbation or have progressed or have side effects. So someone that comes into your office with worsened arthritis would be a good example of a level 4 visit for that. Having 2 or more stable chronic illnesses, so those adding together. One undiagnosed new problem with uncertain prognosis. So if you have someone that you identify has a mass or uncertain what that is, knee pain that's not clear cut what it is, or hip pain. Then another category would be an acute illness with systemic symptoms. So COVID, myocarditis, mononucleosis are good examples of that. And also an acute complicated injury. So something that needs an evaluation of multiple organ systems, has an extensive injury, or has multiple treatment options with a risk of morbidity. And a good example of that would be a concussion. For the data category, there's a lot to unpack here too. So for a level 2 visit, you're not getting any additional tests. For a level 3, you must have two of those three. So reviewing a prior external note from a unique source, reviewing the result of a unique test, and ordering a unique test. So if you're the one that orders a test, you get a point. You can't get 2 points for ordering it and reviewing the same test. So if you ordered a CBC and a CMP, that would get you 2 points, for example. Or the other thing that falls into this category is if your assessment is given to you by an independent historian. So if you have a spouse, a family member is the one that's giving you most of the information, that automatically gives you a level 3. Now, the level 4, you have those same first part of this, but you must have three of reviewing an external note, reviewing the result of a unique test, ordering a unique test, and you get multiple points for that too. So if you ordered a CBC, a CMP, did a synovial fluid analysis, those are three different, you get 3 points and meet the level 4 for that. But also note that instead of it being its own, that assessment requiring an independent historian is woven within that. So that becomes one of the three in that category. There are two other things that would automatically get you a level 4. So if you were looking at an X-ray or an MRI or something that someone else had ordered, and you're independently evaluating that and giving your opinion and your read on it, that gives you a level 4. And if you say you call the radiologist to discuss the case with them and ask them to look at something, that also gets you a level 4, discussing it with an external physician. And then each test is a point too. So again, if you order ankle x-rays and foot x-rays, those are two separate things. They get you 2 points. And let's go into a little bit more detail on this too. So what does the review of a prior external note from a unique source mean? So those are notes or records from another physician or facility, not looking back at your own note, but looking back at someone else's, like the PCP referred someone to you. Ordering each unique test, we covered that. So x-rays, MRI, ultrasound, labs, each lab being a separate point. And reviewing each unique test. Again, to emphasize, you can't double dip and count, I ordered the CBC, so I get a point, but I also reviewed it. That's only 1 point. You don't get 2 points for that. An assessment requiring an independent historian. Again, that's if you got a lot of the history, most of the history from parent, spouse, a witness that was there at the scene. And the independent interpretation of tests, reviewing a study done elsewhere. And then discussing the test with an external physician, whether it's a radiologist, the PCP, talking about the case, or you called an orthopedic surgeon, for example, to go over the case and get their opinion. And then finally, the last category, when you're looking at risk, a lot of what we see falls into these first two categories, the level 3 and the level 4, I should say. But there, for the low risk of morbidity, we're talking about recommending over-the-counter medications, physical therapy, occupational therapy are good examples of what falls into that. The moderate risk of morbidity, if you manage a prescription medication, so that includes whether you stopped something, told someone to continue it, or started something new. The steroid injection with increased risk, this has been a kind of a gray area, I would say, within the medical billing community. It's if you were billing a CPT code for a steroid injection, typically you can't quote unquote double dip and also include that in your risk assessment. That risk is already woven in with the CPT code. However, if that steroid injection has an increased moderate risk and you put that within the chart, that could potentially increase that where you get a level 4 for risk. Say it's someone with uncontrolled diabetes that you choose to do a steroid injection, that may qualify there. Also within the level 4, decision regarding minor surgery or major surgery without risk factors, and the diagnosis or treatment being limited by your social determinants of health. And for the high risk of morbidity, not a lot that we see within sports medicine, but if you're doing intensive monitoring, say you do manage blood thinners and Coumadin, that's one example there. And another one, if you decide to hospitalize someone and work through that process, that's another good example of that. So that's just to emphasize, those are the most common ones, the ones highlighted here that we tend to see in medicine. Well, let's put it all together with an example, kind of a simple example. A new patient that has an ankle sprain. So you recommend home exercises and over-the-counter medications. By auto ankle rules, they didn't need X-rays or any further testing. So if we look at the diagnoses, we would categorize this as an acute, uncomplicated injury. When we go to data, we didn't order anything, so we're going to go with a level 2, minimal or no data. And then for risk, this has a low risk of morbidity. Recommended over-the-counter medications, a home exercise program, maybe physical therapy that would fall into the level 3. So again, using our little putting it all together thing, diagnosis was a level 2, level 3, data level 2, risk level 3. We have at least 2 categories that give us a level 3, or the median of those 3 is a 3. So we would bill a new level 3 for this patient. Now, as we talked about up front, you can bill based on time. Now, this includes the time that you spend on documentation or reviewing notes. Again, on the day, must be on the same date. Make sure you document the time at the end of the note. Something like this: a total of 18 minutes was spent on the patient encounter, reviewing notes and documentation. Auditors can review the amount of time the patient is in the office, and they can add this up if you use it too frequently. So saying you spent 30 to 45 minutes with each patient when you've seen 12 patients in a half day may get you into trouble. So make sure that you're accurately documenting how much time that you spent on that. And this is often used for concussion visits, but can be used for other things as well. So as a summary, use this PowerPoint as a guide to help understand the MDM. And remember, don't rely on how the visit felt as far as how you code. And thank you for watching the video.
Thanks for listening to the AMSSM Sports Economics Bite-Size Series. If you found today's episode helpful, be sure to follow the series and join us for future conversations as we explore the business, policy, and economic issues shaping sports medicine today. Each episode is designed to deliver practical, focused insights you can put to use right away, whether you're in the clinic, on the sidelines, or leading a sports medicine program. Thanks for being part of the conversation. We'll see you next time for another Sports Economics Bite Size.